One result of our work with Disrupt has been a change in emergency medicine physician approaches and understanding to our patients. That as their doctor in the emergency department, we're there not only to address their chief complaint that brought them into the emergency department, but then to also, again, look at the patient more holistically and consider everything from housing and housing insecurity to medication access to follow-up care, to address the underlying issues that may have brought the patient to the hospital and leaves them at risk for returning to the hospital. I sometimes use the metaphor of an iceberg when a patient presents to the emergency department, and they may come to the ED just saying that they're short of breath or they're having an asthma attack, and that's the little tip that we see above the water. But then underneath the water, it may turn out that they have lost their home nebulizer machine and they need that replaced, or that they're currently homeless and don't have access to some place to receive their treatments, or their PCP is retired and they don't have good follow-up, or they were lost to follow-up with the pulmonology clinic, or they just don't know who to call when they have an asthma exacerbation, and so they just call 911. So the idea of broadening our scope and seeing these patients not just as an individual with an isolated medical complaint, but as a sort of entire individual who has all of these sort of components to that make up the cause for an emergency department visit.
And so what initially started off as, let's try to identify people who were health home eligible, soon snowballed into a really large social determinants of health project that had us not only getting agreement on what the screener would look like, getting it into Epic, but then also having the staff on the back end who would be able to deal with patients who screened positive. And since April of 2018, when we rolled out the comprehensive tool, we've screened over 25,000 patients so far. We're screening at about 2,000 to 3,000 patients a month across the ambulatory primary care practices. Importantly, in my role as the Vice President of Community and Population Health, we've been able to use the data on these 25,000 screens to hotspot areas. So we understand it not only patient by patient, but we're also starting to understand issues like food security at the census tract level. Frankly, we could do it at the building level. So that helps us look at issues like what is happening in this particular area. Why is this area lighting up for food insecurity? For instance, each of our hospitals is either squarely in or right adjacent to a food insecurity hotspot. And so that starts to beg the question, what can the hospital do to help bring about more resources in its own footprint? We're not even talking about having to drive 3 miles down the road. We're talking about right here, right now. What can we do as a health system to augment the capacity of the food providers, the food pantries and others, to be able to handle the food insecurity needs of our patients? And when you think about being able to take social determinants of health issues like that and to map them in that kind of geographic way, it really does add another lever for action.
The project was an extreme success, and we're continuing on. And I think that the community-based referral project, the success of it wasn't just in the numbers. The success was showing us that you could have all of the healthcare services in place, traditional services in place, and you could still have gaps in care. And what the pilot showed us was that even with even with care planning in place, discharge planning in place, patients having their home care set up, we're still finding where the patients are going back to the hospitals, and we were able to recognize a gap in care and actually address it, target it, and be successful in supporting our patients. That's one thing. But what I would really love to talk about is the fact of having a for-profit healthcare organization come and sit down at a table with a hospital, with other organizations, many times our competitors, and really sit and brainstorm. So I think that if you want to really look at DISRIP as a success, I really think the successful outcome of DISRIP is that we've never sat at the table. We work together all the time. I mean, moving patients between us, but what we have never done is come together and work as a single team. And I think that that's what I love about the Bronx Bronx Partners for Healthy Community. I think that experience of working on a pilot together with Bronx Partners has really showed us the ability for organizations to come together as one team and not just working together doing their different parts.
Working with Bronx Partners for Healthy Communities has been really powerful for us because not only have they allowed us to expand our Healthy Buildings initiative, but have really been thought partners in thinking about problem solving, troubleshooting in terms of the work that we're doing in the community, whether it's analyzing data, whether it's thinking about an intervention within a building. They have really provided the capacity for us to really address the issues that would keep this program from being a success.
So our organization has been working with Bronx Partners for Healthy Communities, in particular with the direct workforce, home care workers. And what's been beneficial is that we have seen some great outcomes. One of them being that the home care workers feel supported, they feel like they're being heard. They also feel like they're part of the home care team, and their observations and their involvement is of value to the team.